If I put a patient on a Dex drip, that will not be prophylaxis, that will be the other one. And what we do is we start the patient on Dex and warfarin at the same time. So in 3 days when I stop the Dex, the warfarin is still carrying through. Does that make sense? So in about 85% of the patients, all you need is the alpha-2. That's it. Now, some patients might not be able to tolerate the hypotensive effect of the alpha-2. Let's say a trauma victim who has lost a lot of blood or just had surgery and lost a lot of blood and is already kind of hypovolemic to begin with. So instead of using the alpha-2, you can use gabapentin. But that means high-dose gabapentin, 1,200 milligrams to begin with, followed by 800 or 900 milligrams TID, and then you see the protocol to automatically decrease all the medications. We usually send the patient out with no medication.
Does it make a difference? I mean, a lot of people are on gabapentin now for chronic pain. If they come in on high doses of gabapentin, does that make it less effective if you go that path?
That's a great question. So the question is, a lot of people are using a lot of gabapentin. I would say overusing a lot of gabapentin. And then the question is, if those patients are already on high-dose gabapentin, does it make the difference or does it make it more effective? Or less effective? Remember that the basis, and that's why I call it the broth, the basis is the alpha-2. So a patient who is on gabapentin will have to go on the alpha-2 to be effective. And again, the beauty of warfarin is significantly, I mean, we're not talking less, we're talking about significantly less hypotensive than clonidine. So warfarin is more anxiolytic, better for the alcohol withdrawal, and less hypotensive. The problem is the half-life. So long half-life takes a long time to kick in. And that is it. I'm working with some people in Europe to try to come up with a molecule that is better than, and there's two in the market there in Europe. So if the patient is positive, that means that they are at risk for severe withdrawal and they're already withdrawing. Those patients, we start them on both at the same time. So you use twice as much of the alpha-2. So you put 2 patches of 0.2, and then you start them on either gabapentin or valproic acid. So which one do you use? Well, the other day, well, not the other day, this is patient 1. So 7 years ago, I walked into the emergency room because a patient is going through withdrawal, and it was a pain in the behind. So they called me the chief. I walked in with my entire entourage, and I hear the story, and I'm like, this patient is perfect for the Benzo-Sparing protocol. So I walked in, and there's a trauma team and the ER team, and I see the patient who is restrained with 4-point restraints to the stretcher. You can hear that through the entire floor. And the guy meets me by saying, listen, they're recording, so I have to change the language that he used, but he said, listen, you whatever, I am a lawyer, and I'm going to sue your you know what. So I chicken out. Because I thought, if I order my protocol, then I'm going to have to explain to all those 20 people why I'm not using a benzo and everything else. So I said, okay, 2 milligrams of IV lorazepam, just so you can lock him out, and then we put him on the protocol. That patient had been admitted to Stanford 17 times prior to this admission. 10 of those 17 times, he had been in the ICU. That patient received 2 milligrams of Valium, and I remember that patient forever because that was the last time I used a benzo. It was really July 2nd, 7 years ago, and we had never used a benzo again. So I gave him 2 milligrams of Valium, put him on the protocol. The ER hated him so much that they kept him in the ER instead of admitting him to medicine. We discharged him 36 hours later, perfectly fine. Never again did he receive a benzo. And that is how good the protocol works. Now, you can go to our, at drunk tank at Stanford, and I can tell you can tell who the patients are on the benzo and the benzo-sparing. Patients on the benzo protocol are constantly hitting the button, or they're drooling because they receive so much benzos. Because we're at Stanford, the patients on the benzo-sparing protocol are usually sitting at the bedside, reading the New York Times, and complaining that the food is not hot enough. Big difference in terms of the cognitive improvement of these patients. So remember, the broth, the basis is the alpha-2. Now, why do we use 2 patches instead of 1 patch, right? If you remember the prophylaxis protocol is 2 patches of 0.1, and I know that it comes in 0.2. But the reason for 2 patches of 0.1 is that we put dates on the patch. Patch number 1 comes off in 4 days. You already reduced the dose by 50%, and the other patch stops working in 7 days, so it doesn't matter. But we instruct the patient when to take it off. So the same thing, we give 2 patches of 0.2, so the total is 0.4. Remember that you have to administer PO or IV clonidine in order to, allow for that head start of the patch. And then whether we use valproic acid or gabapentin depends on how bad the withdrawal already is. So that patient who was on 4-point restraints in the ER, we gave 2 milligrams of lorazepam, put 2 patches of transdermal clonidine, gave him 0.2 and then 0.1, 0.1, and then load him with valproic acid. And then after that, we switch him over to PO gabapentin. And that's what we did with that patient. Now, this is very old slide. And these are the first 15 patients. And I just wanted to point out, this magenta block is when we started the benzo-sparing protocol and the amount of benzodiazepine that the patient required thereafter. This is data from Kaiser Permanente that our colleagues very kindly have provided us. And the point of that slide is to show Kaiser has now started to using as our benzo-sparing protocol. And they discovered they can reduce the length of stay in the ICU by 5 days average and in the floor by 7 days average. And they have 10 times more patients than we do. And as we have done, they have experienced no progression to DTs, no seizures, and no transfer to the ICU. And as you can see, it's dramatic improvements on the overall length of stay. So don't take it all from me. If we read the literature, you actually see that most of the meta-analysis has shown, and these are mostly studies in Europe. In Europe, we have been using carbamazepine for the treatment of alcohol withdrawal for almost 25 years, that the anticonvulsants and the alpha-2s are considered in Europe superior to benzodiazepines and barbiturates. And I know that benzos are the standard of care, and this slide is for you. Sorry, I forgot your name, but this is the data that we use to decide that benzodiazepines are the treatment of choice for alcohol withdrawal. That is it. After that, we decided benzos are the treatment of choice. Barbiturates are too dangerous, so we switched from barbiturates to benzos, and that's the standard of care. So again, beta blockers don't work. Alpha-2s are superior too, and it's not perfect, 10% failure rate, at least that's what the study shows. I haven't had a failure yet. I know I will, but we haven't yet. And the experience at Kaiser has been just equally good. At Stanford, we have a new protocol coming online at the beginning of the year, where people are going to get on the anteroom of the emergency room the pause. If they're pause negative, they're going to be given some hydroxyzine and sent home. We're not admitting them. If they're pause positive, they get into the back room where they get the AWAS or CIWA, and then we load them, and the plan is to discharge every patient within 36 hours. Because we're that confident that the treatment protocol, 36 hours, yeah. So we are extending the 24-hour observation unit to 36. I predict that after they get comfortable with that window will start to shorten. What we want to do is demonstrate that, the reason for the 36 hours is the risk of seizures, right? We should peak somewhere between 18 and 36 hours, okay? Now remember, DTs, the peak of DTs is on day 4 to 5. So it doesn't matter what you do with those patients. They don't go through DTs until later on. A patient who's gone through DTs earlier than 4 days is because they stopped drinking a long time before you got them, right? It's not when they get admitted, it's when they stop drinking. Yes, sorry?
So those folks leave with 2 patches and meds, and they go home after 36 hours?
Yep. Yeah, what we do is we put the date when we want the patch out. And then we have a follow-up clinic, which is essentially is a combined family medicine addiction clinic. So they come in to see the doctor, but they really end up talking to our detox people. Yeah.
Well, I work outpatient at county, so we get this a lot, and we have to deal with the outpatient. And I have been using valproic acid and gabapentin and clonidine. Do you have a specific outpatient protocol?
Yeah, we have an outpatient protocol, and I'm happy to share that with Karen. The outpatient population, if somebody wants to stop drinking, what I do is I start them on guanfacine early, and I tell them on day 3 you can start decreasing, and then we talk about how much to decrease it. You can use clonidine. The problem with, again, comparing clonidine with guanfacine, if I have a patient on clonidine, I do care about their blood pressure. Your patient is, I don't know how to explain that. I had not had a patient develop significant hypotension because of the guanfacine. In fact, I can tell you that I like guanfacine so much that at Stanford we get a lot of people who are big talkers on big companies and all that stuff, who get anxious when they give talks, and they all have been either taking a benzo like Xanax or a beta blocker, and every patient that I have switched to guanfacine comes back and tells me how much they hate what they were taking before. Guanfacine works so good for anxiety. Yes?
Are you looking at all, I've read that in Europe they're titrating up baclofen to reduce the reward.
I'm glad that you asked that. I knew that this talk was already long enough, so I didn't put all that data, but there's 2 things that we need to understand. When you think about gabapentin, the benefit of gabapentin over the alpha-2s. Alpha-2s are superior for the withdrawal. No question about that. In fact, an alpha-2 alone will treat, as I said before, about 85% of the symptoms of alcohol withdrawal. The benefit of the gabapentin is that it actually delays when people go back to drinking. And there's very good data that shows that if you keep the patient on gabapentin and then add something like naltrexone, that is probably one of the best deterrents for the patient to go back to drinking. The French love baclofen. I can tell you from many experiences in the emergency room that one of the nastiest withdrawal is Baclofen Withdraw. I will never use Baclofen to treat alcoholism, ever. And I know the French they do it, but they do a lot of crazy things too. So does it work? The answer is yes. Baclofen works. The problem is I believe that the treatment is worse than the cure is worse than the disease. But it's really high doses, right? We're talking about insane doses. And again, if you make the mistake and the patient was delirious rather than withdrawing, you can actually intoxicate some. I have seen people being intubated because of baclofen.
How about Topamax?
Sorry?
Topamax?
The Topamax. The problem with Topamax is you cannot ramp up the dose as fast as you could. So there's limitations on the use of Topamax. Yeah.
Some people who are taking guanfacine are advised not to drink because of interactions with alcohol. But have you had any alcoholics who are already on guanfacine and they?
So I think we physicians suffer the same problem that many other people in the community do, which is we tend to be very simplistic about how we treat things. Just because gabapentin is a CNS depressant doesn't mean that it works on GABA, right? So gabapentin and alcohol combination will have a synergistic effect because you're decreasing both glutamate and you're enhancing GABA activity at the same time. But it's not the same thing as if you were to combine a barbiturate or a benzo and alcohol, which then will cause significant respiratory depression. Does that make sense? So they're both sedating, but they work by different systems.
I'm talking about guanfacine.
Oh, sorry,
Guanfacine is used for ADHD, and I would assume that if someone's treating somebody for ADHD with guanfacine, they would tell them not to drink. But have you had any people who are alcoholics and take guanfacine for ADHD?
No, we don't have an N large enough of ADHD people on guanfacine. That's a good point, by the way. 10X, which is a commercial name for guanfacine, is only approved in the United States for one condition, and that is ADHD. And is probably the best treatment for ADHD in the adult. And then second to that, probably bupropion or Wellbutrin. Yes?
would imagine that, what is your criteria for when you see patients?
So the question is, on the benzo protocol that I'm assuming that you use, or did you guys use, you have a low threshold to put people in the ICU, is that? Right. So the question is, what is our threshold of putting our patients in the ICU? In 7 years, and I'm not exaggerating, in 7 years we had never put somebody in the ICU who is timely on the benzo-sparing protocol. Now, we have had people who were either not recognized by anybody, so they end up in the ICU because they were that agitated, so they get started on propofol, and then they call us and we switch them from propofol to Dex, loaded them with guanfacine, took them off Dex on day 2, somewhere between 48 and 72 hours, and then took them to the floor, usually within 24 hours of starting the protocol. So we haven't had anybody on the protocol who failed and went to the ICU. And Clay, I don't know if you know about the experience on Kaiser, but I know Kaiser is presenting at the next month. We have a meeting of the academy, and Kaiser is presenting their data, and they have 0 patients who have been transferred to the ICU. Do you know anything different? Okay. Yeah. So the answer is we don't know of any case. Yeah.
How do you use your treatment arms, both the prophylaxis and the treatment related to polysubstance abuse patients? Because Santa Cruz, one intoxicant is rarely enough.
Yeah. That's that is a great question. You might be right. At Stanford, we might tend to have more pure alcoholics, and almost all of them drink vodka because you guys know why most 500 company CEOs drink vodka rather than any other alcoholic beverage? What? No, it has nothing to do with migraines or calories. Purity. What gives an alcoholic away, besides the stumbling, is the breath, is the alcohol breath, right? So when a patient is drinking Thunderbird, the alcoholic breath is like a Doppler effect, right? I mean, before they get to you, you can smell it. That's not alcohol that you smell, it's the impurities on the alcohol. So the reason 500 companies, people drink vodka and have a nice fridge on their office with vodka is because vodka is the most pure of all the spirits. So it means you cannot detect the breath. And the breathalyzer does not detect the alcoholic content. In fact, I don't know how many patients we have who you can swear that they're intoxicated, and that's because they puke on themselves and you can still smell the alcohol impurities. Breathalyzer is negative because a breathalyzer actually gets vaporized alcohol, not the smell, right? So the smell has nothing to do with anything. It's just, smell is impurities. It's the more pure, the less you can smell it. The effect is exactly the same. So, but to answer your question, so if you have combined substances, then it depends on which other substance you're talking about, right? So we have not been able to demonstrate that this will work with opiates. And in fact, the opiate system is completely separate for the system that we have talked about today. So I will not recommend that you do that. If you have a patient who is using CNS stimulants, the presence of an anticonvulsant and an alpha-2 will actually blunt the effect of the psychostimulant. Patients who who use excess benzodiazepines, could this work? I can't tell you because I haven't done the study. But I can tell you that I use this protocol on my patients who have either benzodiazepine abuse or alcohol abuse, or barbiturate abuse. The difference, though, is the half-life. Half-life of alcohol is not the same as the half-life of Librium. Half-life of Librium is 150 hours. It takes 5 times the half-life to eliminate a drug, so you cannot treat a benzo withdrawal patient with the same protocol as the alcohol, because the half-life of alcohol is 15, 15, 15, 15, and Valium and Librium are going to be there forever, right? So you have to adjust the protocol to match the half-life of the substance. Does that make sense? Sorry, what was that? That's a great question. So as you know, there's a black box warning for the use of IM olanzapine with any IM benzodiazepine. There's no reason why there will be an agonistic effect with this protocol and an antipsychotic. Now, ciprofloxacin is a different story because the main concern with ciprofloxacin, particularly given IM, is the possibility of cardiac dysfunction, particularly prolongation of QTC. So there are many things, as you know, that can prolong QTC. So it really depends on what you're combining there to decide whether it's safe or not. Now, none of these medications in our protocol prolong QTC by themselves. Yes?
So Precedex is an altitude agonist, and therefore...
Sorry, what was that?
Precedex is an altitude
Yes.
agonist rather than SARS. You shed it's far down on the protocol. But if you have a patient who can't tolerate the contrast patch, or there are issues with parental or NPO, the fact that you have to give Precedex in the ICU sort of limits it, right? Is that the reason it's so far down?
I mean, that's a great point. I don't expect that we all know the literature that crazy, but my group was the first one to ever demonstrate that you can use Dex for the treatment of both delirium and alcohol withdrawal. And then that study has now been replicated 7 times. Yes, Dex is not very until down here because Dex has 2 limitations. One, you have to use it in a monitor unit. So you have to be either in the CCU or the ICU or something like that. And 2 is because only available IV. I told you before that if my brother was in alcohol withdrawal, I will use Wanfacine. If my daughter was on alcohol withdrawal, I will use Dex. I mean, the onset of action of that is, for alcohol withdrawal, it's like magic. I mean, you put somebody on Dex, and about 30 minutes later, they're normal. I mean, now, the third argument against Dex was the cost. The cost of Dex is going to go down to be exactly the same as propofol in about 7 or 8 months, right? So right now, just for you to compare, the cost of midazolam is about $50 a day. The cost of propofol is about $250, and the cost of Dex at 0.4 mics per kilo per hour is $1,500. So if you go to 2.4 or something like that, it's dramatic. Now, when you are able to put somebody on Dex now and control all the symptoms within an hour, and then load them with Wanfacine and take them out of the ICU, you far, suppress the cost effect because at least at Stanford it costs about $12,000 a day just to be in the ICU. So, I mean, the cost of the medications is peanuts. Yeah, but you're absolutely right. The onset of action will be far faster on Dex, and we use Dex with all our trauma patients. And you know what? We use Dex a lot in our orthopedic patients. Orthopedic patients and ENT patients are the worst for alcohol withdrawal. The drunks are the ones who fall or drink recklessly and then end up crashing and having orthopedic injuries. ENT patients, alcohol is an immunosuppressant. So when you drink and smoke, you dramatically increase the risk of cancer of the ENT area. So those patients, usually when they come to the hospital and the doctors tell them that you're going to be NPO for a few days, you know what they do? They load up. Not remembering or not knowing the biochemistry, you cannot load up on alcohol because it drops out at the same rate that it drops out. And all those patients end up. Our highest use of our protocol is ENT, followed by our trauma patients. Anyway, any other questions? I don't want to keep you here longer than you have to, but.
Is there any benefit in long-term abstinence rates based on
So the question is there any benefit on the long-term abstinence rate? We haven't done long enough studies on the alpha-2 component, but Mirek, who is down in San Diego, has done studies on keeping patients on moderate dose of gabapentin. Remember, we load them with 1,200, then 800 TID, and then you keep on dropping. He stops at 600 TID and keeps them on that. And the rate of recidivism is cut by 60% on the patients who are kept on gabapentin alone, as opposed to patients who, as in our protocol, come down in 10 days. So there are at least 2 large case series that show that if you combine gabapentin and something like naltrexone or anti-abuse, you dramatically extend the sobriety in those patients. So there are some interesting protocols. Of course, the question is compliance is a problem, right? One of the things about naltrexone is you can inject it. They still have to take the gabapentin. And the other one is, our healthcare system sucks when it comes to substance abuse. So there's not enough of a safety net for patients with substance abuse problem, and that includes alcohol. Yeah.
You were saying that the more you go into withdrawal, the more you're likely to go later. Are you seeing a decrease now that you're starting to intervene early and fewer return customers with these patients?
Yes. So the thing is this, every time you go through an episode of severe or complex alcohol withdrawal, it lowers the threshold for the next episode. So let's say that the first time you went through alcohol withdrawal when you were at a ceiling of 400 milliliters of alcohol in the blood alcohol range, the next time you might withdraw just dropping down from 350. And so you need less of a blood alcohol level to drop from in order to have the symptoms. And then it augments the symptoms. There's a kindling effect every time you go through withdrawal. So every time you go through an episode of withdrawal, it magnifies itself and it becomes more severe, more violent.
But you have data with now that you're blocking early, that you're seeing repeats or decrease in repeats in these patients?
Yeah. So to tell you the truth, at the very beginning, we were not following these patients. We were just praying that nobody will seize and will get sued. And I remember, I distinctively remember those first 3 months when we started the Benzo-Sparing protocol. I volunteered to be on call for the first 3 months for my team. Because I was like, if somebody breaks through, I want to be there. I never went into the hospital. So we didn't start collecting data until probably the last 3 years, and we hope to publish something sometime by next summer. But our experience has been that all those repeat customers, we don't see them as often as we used to. Yeah. Time for a drink? And I have one more question before I let you go.
Hi, my name is Todd Mitchell. I want to welcome you back. You actually came and gave grand rounds here at Dominican probably about, I want to say, 8 or 9 years ago. Mm-hmm. At the time, you were still very heavily into Dex, and you weren't into clonidine. And I'm glad to see that. We actually used a protocol like this very successfully here at Dominican years ago. Mm-hmm. And I have just a few comments about it.
Yep.
We found that it was very helpful, and I've found that it's very helpful. Start the patients on the protocol as early as possible when they're in the ED. Because if you start them on the clonidine, and we were not so averse to beta blocker. We understand the theory of that, but practically we like to see normal vital signs.
Yep.
And if you start them in the ED with an anticonvulsant like Depakote or IV Depakote if necessary, you get their blood pressure under control with clonidine, you get their rate under control, then they don't need to go to the ICU.
Right.
The other thing we're very aggressive about, and it's nice to see that you're also doing this now, is the use of adopting the British system for IV thiamine replacement.
Yep.
Along with that, one has to be very aggressive about magnesium replacement. Mm-hmm. They go hand in hand.
Yep.
But what we found in terms of thiamine is that before we were using high-dose thiamine, there was a small percentage of patients who would not recover on the protocol and who would develop what appears to have been Wernicke's encephalopathy.
Okay.
And the patients who present and require admission to a hospital like Stanford or Dominican with acute alcohol withdrawal syndrome are pretty much indistinguishable from patients who may be suffering from Wernicke's.
Correct.
And so if you just give high-dose thiamine to all of those patients, you're going to prevent those at high risk from converting to Wernicke. And the best benefit of all is that you're going to markedly reduce by repleting their thiamine in the course of treating their alcohol withdrawal, their 30-day bounce back rate. Okay? You replete their thiamine and you've been treating them with an anticonvulsant, you get rid of that kindling effect that the benzodiazepines induce and that repeated bouts of alcohol withdrawal induce. They're repleted, they're much less likely to bounce back in acute alcohol withdrawal in that 30-day period.
I agree with everything you said. I have two comments to make. One is I cannot overemphasize what you said about thiamine, because the problem is that we tend to give people the cheap treatment on thiamine, 100 milligrams PO a day. Alcoholics cannot absorb it. And then we start giving them fluids and glucose, and then we throw them into Wernicke's. So they come in confused, and then we make them demented. That's one thing. The other one is, and I don't know that I emphasize this enough, I think I did say that the reason I ended up studying alcohol withdrawal was because of the treatment of alcohol withdrawal, right? The benzo-induced delirium, and what I was studying was delirium, not alcohol withdrawal. But let me emphasize something else. I show you the data from MGH. You have a 42% incidence of you causing delirium because you're giving patients benzodiazepines. The story doesn't end there. Every time a patient gets delirious, they have a 40% chance of never being the same. So I don't know if you saw the last weekend, our very good friend and competitor Wes Eli had an article on the New York Times about how delirium is one of the main precursors of dementia. And I don't like when somebody preempts me. We have a study coming out showing, the title of the paper is Why Grandpa Hasn't Been the Same Since Surgery. And the punchline is, because he had a successful surgery, but he got delirious in the hospital, which gives you a 40% chance of never being the same. So I'm not saying that if you get delirious, you have a 40% chance of getting demented. I'm saying that if you were here at this level of functioning and you get delirious, you have a 40% chance of never getting back there. And some people are just in the cusp between dementia and good functioning. So if we push them over that edge by causing delirium, then I think you should feel guilty that you caused premature dementia. So really, I just want to point out, I only got here because of the delirium, and I'm very serious about trying to prevent delirium. So the reason I don't use benzos is because of all the medications that we use is one of the main predictors of developing delirium.
I just want to make one other comment, and that is agreeing with you on the benzos. And what we've seen in the hospital is that benzos induce disinhibited behavior. Mm-hmm. And it's very difficult to have the patient participate in their own care when they're exhibiting disinhibited behaviors. The really nice thing about using Depakote is that not only is it very effective as an anticonvulsant, but it makes very difficult patients much nicer, much more cooperative with care, much more able to participate in their own care, and reduces those disinhibitory behaviors that are such an impediment to caring for patients.
Go ahead.
Not the title of your talk and not the reason you're here, but if the main goal is to prevent delirium, I see preventing falls as part of that spectrum, and that
yes.
plays to that as well. And so frequently, I'm a rehab doc, and so frequently I'll consult psychiatry to try and get help to deal with a patient's anxiety and their lifelong benzo use, and knowing that when they are on their opiates for their hip surgery and then their long-term benzo, and we're increasing their fall risk, they're here to get the fall. But go to anxiolytics or coping strategies to get through the anxiety in the hospital. People already laugh at me because I use gabapentin for it. I try not to use it in cholinergics because of the same reason.
Right. Yeah. But remember, they're anxiolytics and they're anxiolytics, right? I mean, but you know, we are used to the fast-acting anxiolytics, the easy ones, which are barbiturates and benzodiazepines. But they're not the only one, right? You can use antihistaminic as anxiolytic. The problem is that the antihistaminic have significant anticholinergic effect, at least the first generation. which are the best anxiolytic, but guanfacine and the alpha-2s are excellent anxiolytic medications that have no GABAergic effect and no cause of delirium themselves. I mean, truly, using a benzo to treat alcohol withdrawal is the same as using methadone to treat heroin withdrawal, right? We're using a substitution method, and it does not address the underlying pathophysiology of alcohol withdrawal. And with that, I'll let you go. Thank you very much.